Hi everybody, and thank you to the Voice Foundation for organising this online virtual 49th Annual Symposium Care of the Professional Voice. It's my great pleasure to present to you today our research findings on how individuals cope with chronic dysphonia, a cross-sectional study. I'd like to acknowledge my co-researchers, Jared Hermogenes, Associate Professor Stephen Cumming, Associate Professor Janet Baker. I'd also like to acknowledge the Australian Dysphonia Network, who provided financial support via a student scholarship for Jared in 2018. Dysphonia occurs when abnormalities in the pitch quality and loudness of one's voice impairs communication and thus affects quality of life. A systematic review in 2017 documented significant debilitating effects of dysphonia on psychological, social and occupational outcomes of those with voice disorders. Now, chronic disorder is defined as one that occurs for at least 4 months, so dysphonia can be considered either chronic or acute. Coping is defined as behavioural or cognitive steps taken to manage the stress of a disorder. In this study, we've used Epstein's model of coping. This model describes 2 broad coping styles of individuals with dysphonia. First is problem-based coping, which is more focused on problem solving, such as attempting different solutions like voice therapy, whilst emotion-based coping, on the other hand, aims to deal with the emotional consequences of a disorder, such as denial or distraction. A systematic review in 2003 emphasised the direct impact of adaptive coping strategies on improving physical, social and occupational outcomes related to chronic illnesses. Epstein's study revealed 4 distinct subtypes of coping styles present within the population. Social support, where an individual accessed interpersonal support for emotional reassurance and self-esteem. Information seeking, where an individual actively sought information related to the disorder. Passive coping, where an individual did not adopt or reject any proactive coping strategy. And avoidance, where an individual utilised denial, withdrawal and reorganisation of routine activities as a consequence of their dysphonia. Now, between these studies, relatively little research is focused on coping with voice disorders. Amongst these, most have investigated the experiences of specific occupational groups or those with specific voice disorders, such as spasmodic dysphonia or muscle tension voice disorder, and none have focused exclusively on chronic dysphonia. So our research aims more broadly to describe the coping styles of individuals with chronic dysphonia and to investigate relationships between coping styles and quality of life activity limitations and participation restrictions in voice-related activities. The secondary aim was to explore differences in patient-reported outcomes as measured by 3 validated patient-reported outcome measures and a qualitative analysis of free responses between individuals with different coping styles, illness and demographic variables. We had 79 respondents to our survey, of which only 43 were eligible. They were aged between 21 and 77, who had a formal diagnosis of dysphonia from an ENT or SLP for longer than 4 months. We excluded participants who had concomitant speech and language disorders, voice disorders that were a result of psychological disturbances, or hormonal voice disorders. We recruited our participants through posting advertisements on social media, through voice disorder support groups and promotion by different peak bodies. We opened recruitment in May and concluded at the end of September 2019. We utilised a cross-sectional descriptive study approach to exploring coping styles and trends present within the population. All participants completed the online survey through Qualtrics, and eligible participants were asked to complete a demographics questionnaire that collected relevant information such as those listed on the slide. Participants were also asked to complete several self-report questionnaires, including the Voice Disability Coping Questionnaire, which looked at the individual's voice-specific coping styles and strategies. They completed the Voice Handicap Index 30 and the Voice Activity and Participation Profile, which evaluated the individual's self-perceived quality of life and activity limitations and participation restrictions in voice-related activities, respectively. Descriptive statistics were used to identify trends in particular coping styles within the population. We used correlational analyses via Pearson's R coefficient and one-way ANOVA to investigate the relationships between different demographic factors, coping styles and strategies, self-perceived quality of life, and activity limitations and participation restrictions. Our results revealed that study participants were mostly diagnosed with spasmodic dysphonia, followed by muscle tension, voice disorders, and vocal fold paralysis. Most participants from the study also received their diagnosis from an ENT, speech-language pathologist, or both. The majority of the research participants in the project reported having dysphonia for longer than 3 to 4 years, with an average of 6.5 years duration between their first symptoms and current diagnosis. 40% of participants reported that their voice disorder diagnosis had changed through the duration of the voice disorder. 86% of individuals had accessed voice therapy, and 40% of participants reported a co-occurring medical condition to their chronic dysphonia. 53% reported being a professional voice user, or those who use their voice in a professional capacity. When compared to findings from previous studies, those with chronic dysphonia utilise more coping strategies on average than those with occupation-related voice disorders. Individuals with chronic dysphonia also reported on average a moderate level of quality of life impairment, but relatively high levels of restrictions and limitations on their activity and participation. This graph shows the type of coping styles that were adapted by the participants. The information-seeking coping style was the most commonly reported from the population, followed by avoidant coping styles and passive coping styles. The least reported was social support. This table represents the correlation between the VDCQ subscale scores and participant scores on the VHI-30 and the VAP, as analysed by Pearson's R. The variables compared were the VAP and VHI-30 total scores and scale scores for the self-perceived severity of the voice problem. Effect on employment, daily communication, social communication, activity limitations, and participation restrictions. As you can see, significant correlations were seen between scores of the VHI-30 and the VAP, and those with passive and avoidant coping styles. This table represents different illness and demographic factors and their correlation between the different patient-reported outcome measures as analysed by Pearson's R. The variables compared were the various scale scores of the VDCQ, VHI-30 and the VAP, and demographic factors such as change in voice disorder diagnosis, being a professional voice user, a concurrent medical condition affecting the individual's voice condition, access to previous voice therapy, and whether they confided in others about their voice disorder. From the analyses, there is a significant negative correlation seen between age and their self-perceived impact of voice disorder on their quality of life and its effect on their activity and participation. Group T tests revealed no significant differences between the scores of the VAP, VHI-30 and VDCQ, and individuals who had a change in diagnosis, had a medical condition affecting their dysphonia, accessed voice therapy and used social supports to confide in others. However, those who identified as a professional voice user reported higher scores regarding the occupation-related impact of their dysphonia than those who did not. And of course, this is not surprising. We then completed a summative content analysis of free responses from the study to analyse the self-perceived efficacy of social supports within the population. Now, despite only 2% of participants reporting that they actively use social supports as their preferred coping style, a majority of participants, that is 74%, held the belief that accessing social supports was an effective way of coping with their chronic dysphonia. So a very interesting contradiction there. Three main themes emerged on why social support was effective from the free responses: sharing experiences to provide insight and inform empathy, an effective way to manage the emotional stress and frustration of dysphonia, and an opportunity to receive support from others with similar experiences. 26% of participants reported that accessing social supports was not an effective way of coping with their chronic dysphonia. Thematic analysis revealed a perception that those without a chronic voice disorder lacked a genuine understanding of their experiences, or that other individuals had accepted the chronicity of the disorder and its pervasiveness in their lives. So the first aim of the study was to determine the self-identified coping styles of individuals with chronic dysphonia, and the majority of participants reported information seeking as their main coping style. This is consistent with similar studies on coping styles in teachers who sought treatment and had occupation-related dysphonia, and those with spasmodic dysphonia and muscle tension voice disorders. Participants in this study presented with a VDCQ mean coping score that was substantially higher than scores reported elsewhere in the literature. This elevated score demonstrated that individuals with chronic dysphonia were using more coping strategies on average than those with occupation-related dysphonia and general dysphonia. The results of this study indicated a strong correlation between the passive and avoidant coping styles of the VDCQ and higher scores on self-perceived voice disability. Passive coping styles were significantly associated with disability in social communication, emotion, activity limitations and participation restrictions. These disability scales were also significantly associated with avoidant coping styles, with the inclusion of disability in occupation and daily communication. These findings suggest that avoidant passive styles are associated with poorer outcomes. The long-term use of these coping styles may have resulted in circular patterns of avoidance and passivity in everyday activities with a more profound impact on individuals' quality of life. The study found no significant differences between the scores of individuals with different coping styles and their quality of life outcomes, activity limitations and participation restrictions. So there were also no significant differences in scores between those with various illness and demographic factors within the study, with the exception of being a professional voice user. It is reasonable to extrapolate from previous research completed on coping that individuals with chronic dysphonia face complex health-related and emotional challenges in navigating the experience and perception of their disorder. The majority of the participants in this study believed that seeking social supports was an effective way to cope with chronic dysphonia. But this was in stark contrast to the data collected from the VDCQ, which had social support as the least endorsed coping style. So given this discrepancy, it's important to consider that social support may have different subjective meanings and implications for different individuals, and again reaffirms how individual perceptions and understandings of illness may have an impact on how we seek support. So limitations of the project include that it was mostly represented by individuals with spasmodic dysphonia, so it may not account for how different voice disorder groups experience their disorder. The exclusion of other voice disorder groups' experience, such as those with psychogenic dysphonia, also limits the scope of the study. Also, as a cross-sectional study, it does not describe and follow changes in how coping styles and strategies change over time. But our study does provide foundational knowledge about coping strategies present within a population with chronic dysphonia. Future studies could include more diverse diagnostic groups or an adjunct qualitative study that explores the highly personal experience of coping with a voice disorder. Longitudinal studies that map these changes in coping styles over time would also be very, very valuable. So in conclusion, based on the results, individuals with chronic dysphonia experience significant impacts on their quality of life, activity limitations and participation restrictions as a consequence of their voice disorder. It is therefore important for voice practitioners to recognise the importance of holistic support which recognises the diverse experience of these individuals. Given the tendency of the population to orient towards information-seeking coping styles, it's important for voice practitioners to ensure that they have accurate, reliable information that's readily available to patients to assist them. And voice practitioners are encouraged to recognise individual experiences and coping styles through open conversations that will enable individualised care that reflects a deeper understanding of the patient's experience of dysphonia. This will promote increased knowledge of services and support systems, assist in fostering healthier coping styles, and to recognise maladaptive coping strategies during the course of the disorder. Thank you very much.